Jessica Ann Treader, as Ruby said, clinical professional development educator in maternal child, the co-chair of the Interdisciplinary Research Council. On behalf of the council, along with my co-chair, Ann Langen, we would like to welcome you to Amplifying Research and Evidence-Based Practice. Thank you for being here. Thank you for attending. We hope to inspire scholarly inquiry while creating excitement for research and EBP here at North Shore. In research, the first question is always why. Our talented speakers today will give you an in-depth look at how, which is the next question in conducting research. How do we do this? Pascal Hogu is a research manager at the Feinstein Institutes. As a nurse, Pascal worked at North Shore University Hospital in telemetry for 15 years. She was a member of the Collaborative Care Council and Interdisciplinary Research and EBP Council. On 2DSU, Pascal was the skin and heart failure nurse champion. She maintains PCCN certification and CVRM. Pascal spent 2 years at Feinstein, first as a clinical research nurse, and then a year later promoted to manager. She has a bachelor's in psychology and a BSN while currently pursuing her master's in public health. Welcome, Pascal Hogu.
I'm supposed to put something in the chat. Hey, Patrice, it's Ron. How are you? Good. You know, I don't know if you. Good afternoon, everyone. Thanks for having me. Nursing provides multiple career pathways in specialty areas for those who wish to pursue it. I will speak about my choice, which is clinical research as an option for nurses. First, what exactly is clinical research? It is a branch in the health field focused on improving our knowledge of diseases and how we treat them. We do so by identifying areas of need, designing a study, recruiting research participants, implementing the protocol as objectively and precisely as we can. This protocol may involve testing a new drug or device, or testing a drug or device that is already on the market to see if it is effective for something else. The ultimate goal of research is to treat and cure diseases, extend life, and improve its quality. Antibiotics, vaccines, surgical procedures, technologies, the interventions that we bring to the bedside, much of that came from research. As our talk today is focused primarily on nurses, the question is, what do research nurses do? As with nurses anywhere, we tend to wear many hats. The primary role of a clinical research nurse is to execute a research protocol. The tasks involved in the protocol are much of what nurses do elsewhere. We administer drugs, we insert IVs, we do EKGs, we draw blood. In the case of research, the drugs that we were administering are often investigational drugs that have not yet been approved by the Food and Drug Administration. They have shown promise in animal studies and have received authorization to be tested on people. Most of the studies that are implemented where I work have already been designed and approved by the Institutional Review Board. However, once I read the protocol, if there is an idea that I have as a nurse that can benefit the study, that can make participants more comfortable, I will voice that idea. Oftentimes, the protocol will be amended to include the voice of a nurse. Ancillary roles include recruitment of study volunteers, educating about diseases, about the study itself, and helping the investigator with the nuts and bolts of getting a study going. For example, a new investigator might need to know, how do I order supplies? How do I arrange for stat lab pickup? How much is it going to cost? Nurses can help answer those questions, or at least link study personnel to the right contacts. Nurses in research are also managers and directors. They function as sub-primary investigators and in some cases qualified to be investigators. At Feinstein, the Clinical Research Center also serves as an informal or unofficial employee health service. So in addition to research, we also coordinate the annual flu pod, we do blood drives. My colleague and I both worked in cardiology, so we love conducting an event on Go Red for Women's Heart Health. We provide education on recognizing the symptoms of heart attack in women and practice chest compressions. We also joined the system-wide fight against opioid addiction by raising awareness, providing education, and distributing knocking kits. In this slide, you see pictures of members of Boy Scouts Troop 300 of Hempstead who were working on their health professions merit badge. In addition to learning about the opioid crisis, the Scouts got a tour of our new state-of-the-art laboratories on the 4th floor of Feinstein. So I've been asked, what made me go into research? How did I go? How did I get involved in it? Like anything else, there needs to be an interest. If you are someone who has an inquisitive mind, you like to observe and you like to question, what is the best way to help someone get better? What does the evidence show? If you are driven by a desire to learn, to do your job better, and if you want to advance the profession of nursing, consider research. After many years at the bedside, there came a time when I asked myself, what's next? There were many great possibilities, and it was challenging for me to decide. Research crossed my mind. I enjoyed learning about it. I attended a lot of conferences, and I brought the knowledge that I learned to the bedside and shared it with my colleagues. To help me decide if research was right for me, I joined this hospital's Interdisciplinary Research and Evidence-Based Council. And there I met like-minded and resourceful professionals. To prepare for a project, I needed to learn how to conduct a literature review. They told me about city program, about human subject research training, conflict of interest, good clinical practice. And very importantly, they told me about ethics and consent in research. They encouraged me to start a quality improvement project on 2DSU, which my mentor, a nurse scientist, Dr. Annie Jacob, helped me design. The project compared 2 different brands of cardiac electrodes. We chose this because some of our patients developed skin rashes from the electrodes, and in other cases, the adhesive was so strong for thin skin that it glued to the skin and it caused bleeding when we attempted to remove it. For several years, there were 2 brands used on the unit. There was a standard brand that everyone received, and only if they developed a problem did we go looking for another brand that was considered good for sensitive skin. So as the skin champion, our question was, how often do rashes occur? Which electrode is better? So we set out to do a quality improvement project and compared each electrode. This involved All hands on deck for the PCAs, the nurses, and our leadership. At the end of the project, we learned that one of the brands was gentler on the skin. And since then, we were able to enact change on our unit to use a different brand. This project was accepted at the Magnet conference in Atlanta, where I presented the poster. The team also developed a video that we displayed a few years ago at the nursing grand rounds. One day I was working at the drive-through for COVID testing for patients who needed to enter the hospital for surgical procedures. And a nurse came up to me and said, "Do you know anyone who's interested in a nursing position in research?" And I was so surprised, and I told her I'm interested. And since then, I was hired and became promoted 2 years later. What do nurses bring to the table? Nurses bring skills. We bring leadership. We bring creativity. We bring lots of resources, our connections and know-how. What do we get out of it? A sense of accomplishment, of purpose, of knowing that we are helping to advance science. According to the Office of Clinical Trial Research, there are over 400 nurses involved in research at Northwell. Listed are some of these studies that we have participated in, along with studies that are coming up. We've helped advance or create a new drug for postpartum depression that was tested at Zucker. We conduct studies on lupus, endometriosis. We are involved in cancer research. Currently at the clinic, we are testing a new Alzheimer's drug. We've come to the hospital here in the emergency room and administered an infusion for acute pancreatitis. We have been involved in genetics research. Coming up in a couple of weeks, we will be testing a device that's called a neural tourniquet, where we will stimulate the vagus nerve and to see if we can actually slow bleeding down by stimulating the vagus nerve that sends a message to the brain. Technology such as that could help in a woman who's hemorrhaging after labor. It could help in victims of car crash. It could help a soldier on the battlefield. So I'm really looking forward to that study coming up in a couple of weeks. In short, I'll leave you with a couple of words. Whatever profession, whatever discipline you pursue in nursing, be part of the advancement of new knowledge. Bring the best evidence to the bedside. Volunteer for research. Create a project, participate in a project, and advance cures for diseases. Thank you.
Thank you, Pascal. Very inspiring. We all want to join you now, but we can't. Not everybody can go. Our next team of presenters, the 4 Cohen EBP team. Would you like to come up now? The 4 Cohen EBP team will discuss leading the 4 Cohen unit-based EBP project. Melissa Shariah Graham, BSN Clinical Ladder 3, is a co-chair of the Clinical Ladder Council and chair of the 4 Cohen Journal Club. Diane Grassi, MSN CNRN, is a nurse mentor in nurse mentorship program at North Shore. Laverne Brown, MSN SCRN, is a member of the Clinical Ladder program at Level 3. Shalisa Hernandez, BSNRN, Clinical Ladder 3, and 4 Cohen County Champion. Thank you for being here.
Good afternoon, everyone. We're here from Fort Cohen to present our evidence-based practice project. Our project is using gastric aspirate pH testing for NG2 placement confirmation. Our team is made up of myself, I'm Diane Grassi, along with Melissa Shariah Graham, who's our team leader. And the members present today are Shalisha Hernandez and Laverne Brown. And in our audience, we have our educator, Emily Castro, who is very influential in this project. And part of our team as well is Soon Young Yun, who is part of our EBP project as well. We've been supported by both Emily Castro and Ann Langen, who's our research chair, our nurse managing team, Danielle Gonsalves, Tiffany Ali, Lovelyn Aguilia, and Joy Orr, our director of patient services. Now, Melissa will speak a little bit more in detail. Okay.
Good afternoon, everyone. Welcome. I will start by discussing the background information. The gold standard for initial verification of orogastric or neurogastric tube placement among hospitalized patients is a chest X-ray confirmation. However, it is not feasible or advisable to have X-ray for ongoing verification of accuracy of tube placement, as this warrants an X-ray frequently for feeding and medication administration purposes. A review of literature failed to identify the accurate method for ongoing verification of gastric tube placements. Instead, the literature suggested a variety of methods, such as noting of distal tube length, pH measurement of gastric aspirate, with levels varying between 1 and 5.5, observation of aspirate for color and appearance, irrigation with return of gastric contents, observation of patient symptoms such as respiratory distress, end-tidal CO2 volumes, auscultation, and the use of unnecessary additional radiographic studies. There are many studies suggesting the gastric aspirate pH testing as a valid and reliable test to verify the accuracy of tube placements on an ongoing basis apart from X-ray verification with other methods such as tube length and/or patient symptoms. The researchers recommend a pH value of less than 5 to 5.5 as most reliable. Our EBP question is, in hospitalized patients with feeding tubes, nasogastric/orogastric with initial X-ray verification of tube placements, does ongoing placement verification prior to feeding/administration using pH testing as gastric aspirate and noting the length compared to the current practice, audible air injection, and the distal tube length, decrease the occurrence of adverse events and outcomes. Example, delay in feeding, medication administration, aspiration, etc. Our agenda for today is 1, how Fort Cohen got selected as the pilot project unit. 2, creating the team. 3, creating the structure and process. 4, staff education. 5, implementation. And 6, outcomes. And Diane will be speaking. Thank you.
So how Fort Cohen got selected as the pilot unit. So we started this EBP project as an extension of the work that was done at Cohen's Children's Hospital. The staff at Cohen's trialed this in pediatric population and currently is using the gastric aspirate pH as the sole means of identifying accurate placement of an NG tube. Since our unit, Fort Cohen, is a neuroscience unit, our patient population often requires the placement of an NG tube. For example, if someone has had a stroke or other neurological injury, their swallowing mechanism may be impaired. This impairment is objectively found by a failed dysphagia screen. When this occurs, an NG tube is placed for medication administration, hydration, and nutrition. Our unit was selected because we have a high number of the need for people with NG tubes. And when we embarked on this study, we needed to create a team. And so Emily and Ann, our two nursing education leads, collaborated with our nursing management to select a team of highly engaged nurses and people who are eager to participate in research. Melissa was picked as our team lead, and with the assistance of our managers, we came up with a dynamic team of both day and night shift nurses that will be participating in this project.
I'm going to speak about the structure of how we run our meetings and how our team actually works. So to begin, Am and Emily introduced the EBP project to us as a team. They also provided education on the use of the gastric aspirate pH testing in order to confirm placement of NG tubes. Our meetings are held, they're coordinated by Melissa, and they're held weekly via Microsoft Teams. So being that Cohen's Children's Hospital started this practice, we reviewed this, and then we customized the details to meet that of Fort Cohen and our patients. A one-pager was created, which includes the patient selection process and explains the process for using the gastric acid pH indicator, which we call the right spot pH indicator. So that's the device that we will be using.
So on Fort Cohen, we are currently in the staff education phase of the project. We have all completed an iLearn module that was created by our educator, Emily Castro. Ann Langhan coordinated an in-service program with the vendor who supplied the right spot pH indicator device. We subsequently met with the vendor's educator and have been in service on the use of this device. Going forward, the staff on Fort Cohen will be trained on the use of the device by those who have received training, and we will complete a formal competency for all staff.
This is what the right spot indicator looks like. But in order, you'd be surprised, we weren't prepared really. You would be surprised how the path to this, the use of this device has been a very lengthy endeavor. Since it's a new product that will be used in the inpatient testing, we were advised that the gastric pH device would need to undergo quality control testing. Ann Langen was instrumental in this aspect of the project. She worked with our lab to have them set up a quality control process for our team to be able to utilize the device. It took time, but as of now, we have 200 devices that have been through the quality control process and are ready to use for this project.
Hi, everybody. So this is a good part. We have all been waiting for the measuring part. So our goal is to gather 200 samples for this project. We are looking at how medication administration and the start of tube feed are impacted by X-ray confirmation. Our hypothesis is that by using the right spot testing device and the RN adhering to the protocol, we can improve patient care by preventing or decreasing the delays that comes with X-ray confirmation. All of this information that is obtained will be documented on a created log. So talking about outcomes, we are looking for safe administration We're preventing aspiration, and we're also preventing delay of hospital care and also cost effect. And also decreasing the effort of exposing our patients to radiation. Okay. So the future plan is there have been many hurdles and we have had to manage throughout this process. But we are very close to being able to starting the trial of gastric pH device. Stay tuned for our results. We may effect change on how nurses confirm NG2 placement.
Thank you to our 4 Cohen EBP team. We truly appreciate your dedication and commitment to evidence-based practice and performing research here. Thank you. Our final speaker is Tessie Thomas. Tessie is the clinical nurse educator in the neonatal ICU. She is certified in neonatal intensive care nursing while being a clinical nurse expert in neonatal care. As a member of the Research and EBP Council, Tessie is an award-winning published author of clinical research while being a supportive mentor to our team. A personal mentor for me as well. Thank you, Tessie. Please welcome Tessie Thomas.
Good afternoon, everyone. Thank you, Jessica, for the kind words. So earlier, Jessica was talking about the why, and today we are here to hear about the how of it. So we had an idea, and how did we publish our idea? This is what I'll be talking about. So in 2014, our lead physical therapist, Tom, introduced us to Q-based feeding concept and informed us of our upcoming conference in Q-based feeding. So 10 of our NICU RNs, along with our manager, Debbie Graber, attended a full-day conference on Q-based feeding and explored the feasibility of translating the practice based on best evidence. So the 10 RNs who attended the Q-based feeding conference were identified as a core team primarily responsible for implementing the EBP QI project. The core team conducted a literature review. We presented our proposed EBP project to the institution's Research and EBP Council, Administrative Leadership, and Educational Department for support and potential funding. Training included 4-hour online education modules, and resources were developed for staff as references. At completion of the staff training and education on a preset date, the project was officially implemented in the NICU. Implementation process included using the champion model for rollout to assist with provider order writing, documentation, and peer education. Project champions provided support, reinforcement, and feedback to the NICU team through daily brief at the beginning of each shift. Based on the project implementation plan, many parents came in to give the first oral feeding to the infant. The staff continued working with parents to reinforce the new practice change. During this project, we learned that Q-based feeding implementation supports best practices by demonstrating patient-centeredness. This was evidenced by earlier attainment of full oral feedings, decreased length of stay, and increased parent involvement for a vulnerable population. The project also enhanced nursing staff's empowerment to take the lead as patients advocates in infant feeding practices. By taking responsibility and ownership, the nursing staff recruited parents for feeding partnerships with their infants by providing education, hands-on training, and support. So that was our EBP QI project. So this is what we did. Now, how did we translate this into publication? And why did we do this, or how did we do this? So in literature review, we found out that there was gaps in our practice, and that's why we went for the conference. We implemented the project, the concept, and we wanted to make sure that our findings were easily discovered and widely disseminated. As you see on here, the timeline, even though we went for the conference in 2014, we only thought about writing an article only in 2019, and we were only able to publish in 2021. So the key things that we found that was helpful was that selecting your authors. So authors should be an individual who have contributed in a meaningful and substantive way to the project's intellectual content. So we had 4 authors. One was our nurse manager, one was nurse scientist, Dr. Annie Jacob, and then one was our nurse, the dietitian, and then myself. So as you see, our authors worked in different professional roles that contributed tremendously. The lead author will be responsible for keeping the team on track on time and allotted tasks and sending out emails. Co-authors are responsible for the assigned role in writing the manuscript. Then the next thing that we selected was our journals. One of the things that our team decided to do was to pick the journals and email the editor and find out if they were interested in publishing the topic at hand. We picked journals relevant to our patient population, and this is very time consuming. But what helped us was that picking the journals that we wanted to, it helped us to narrow it down to one journal before going through the task of or getting burden of reformatting and formatting of the article and getting rejected. The next thing that we did was we outlined. So the earlier slide that I showed, that was our bullet points. So we had everything outlined, and we emailed to all the authors with deadlines and assigned tasks. And please make sure that all your emails are short and sweet, because no one is going to read any lengthy emails. Must be clear and concise. And then weekly and monthly in-person and virtual meetings were conducted. Reminders were sent out, many reminders. And this is the responsibility of the lead author. And this helped the team to be in track. And the article was submitted on 2020. And we wanted to make sure that we submitted this before the summer began, because everyone was busy during the summer. And then we had total of 3 revisions, and third time was a charm for us. We'll talk about this in later. And after the revisions, we received our official mail on February 2021 that our manuscript was accepted for publication. Production of the manuscript begins next day by the journal, and that was a happy month. Now, what were the key strategies that helped and that did not help? So our first meeting was all about brainstorming. So 4 minds getting together and brainstorming, what should we do? How should we write? Why should we write? And this is when we came up with the idea of approaching journals before we start writing the articles. Then we expanded on our thoughts and ideas. That second slide that you saw was just our thoughts. We just put it in bullet points, and then we connected the dots, and then we started to make complete sentences of it. For example, like initially our title was like NICU's journey to change culture through evidence-based practice, which changed to implementation of cue-based feeding to improve preterm infant feeding outcomes. So we changed our titles as we started to write our manuscript. Planning. That's a big task, and that's what the lead author undertakes. So the lead author must plan and have backup plan for meetings, room availability, and cancellations. As all projects, we had our share of bumps in the road, like one of our authors left Northwell, but she still continued to be the author, we were happy with that. And 2 of our other authors were in the North Shore Manhasset campus, and one was nurse scientist who worked in a different campus. So it was very hard to find a time that was available for everyone. So the key part of the lead author or the lead author's main job is to be on top of all things with anticipating the worst. It can be hard, and it was hard at times, but we got through it with each other's support. The next what we did was for the next 4 months, we just did drafting, proofreading, drafting, proofreading, drafting, proofreading. One of the things that we noted very early was that we had already started writing our manuscript in one of the Jorgen Square guidelines, which helped us because we did not have to rewrite everything again. And then the barriers. So as we know, time is very essential and plays a very crucial role in writing a manuscript. Each one of us had a full-time job, were full-time mothers, and were involved in various professional developmental activities. We had to set apart time daily and weekly, and this helped us tremendously as I had taken the role of the lead author. We were all full of ideas, but these ideas had to be translated into words and sentences. We wanted to write down our ideas and thoughts, which at first did not make any sense. And then we started to connect our dots. In our team, and Dr. Jacob had experience in writing and publishing, and all three authors did not have any experience. So make sure you have at least one person who has some experience in writing, because having Annie in our team helped us, because she would say that, like when we do our proofreading and when we did our drafting, she would say, oh, this is not how you should write, rather than writing 20 pages and then going back from page number 1. So that actually helped having a very experienced person as a mentor in your team. What helped us? Having a mentor, as I said earlier, is very helpful. And as Annie had experience in writing and publishing, she helped us to develop and improve our writing skills, and which was for all the other three authors, this was our first time writing a publication or publishing in a journal. She helped us to organize, review, critique our work, which helps us to be on track with our manuscript submission. The other things that helped us or facilitated us was that if you call up the publishing article or the publishing journal, they will actually send you free resources. So one of the advantages of emailing our journal editor before writing and submitting the article is that the editor sent us multiple articles related to the QI projects, which was published in their journal, and also introduced us to writing guidelines. And one of the resources that the editor sent to us was a free webinar named Content and Manuscript Submission Tips for the Jargon, which was very engaging webinar, and they shared information about the journal audience, and what to consider before submitting. The other resource that helped us as a team was the Northwell Research and EBP course. So our mentor, Annie, had advised all of us to attend these courses to develop our writing skills and to get an idea of what a publication is. So we attended the publication workshop Basics 1, writing, and 2, writing article submission by Dr. Jane White. These are 2-hour sessions and was very beneficial for a beginner. These sessions gave us an idea of what to expect, and there was a lot of tips and suggestions. And there are other courses also offered by Nursing Research and EBP, and is available in the iLearn. Review process. So this was the most tedious of all, because when you are waiting to hear back that happy news from the journal, and then you get like a 10-page document with all the corrections to be made, you cannot explain that feeling. As a team, we looked at the positive aspect of that, because we were thinking, oh, the journal did not reject us. We still have some hope. So as you see in the table, we have received all our suggestions, which is by the 3 editors. Usually they have 3 reviewers, and they also give us a deadline to submit the review. The editors provide specific format to write the responses. If you look at the left side table, you will see that we got our first review was at 7/2020, but we asked for an extension. Do you remember what happened during that time, 8/2020? Okay, COVID, yes. So due to the COVID crisis, a lot was changing and evolving in our health system, which all the authors were an integral part of. So we asked for an extension for our first review. And the first review, after all the corrections, it was actually 22 pages. And our second review came down a lot, was only 5 pages, and we were very relieved, and we submitted the revision on time. It was much easier the second and the third time, and our third revision was almost similar to second revision, but now we were pros in reviewing, so we were like, okay, let's just get it done within few days. And one of the things that we wanted to point out, that even though the reviewers disagree on some of the ideas, and if we as authors think they are correct, you have to give the proper explanation. We learned a lot. One of the main things that we learned was patience. Any journey, you need a lot of patience. So this was a journey, and like all the other journey, patience is the foremost and most important. There were frustrating times, especially when the ideas and thoughts are not following or flowing and was stuck. And when there's 10 pages to be revised after you spend 4 months in writing that article. Teamwork is very essential, and I would say that that was one of our strengths. Everyone took their responsibilities seriously and completed the task in time. If there's a team, there should be a team leader Don't assume that one person will take lead. You should always have a team leader. Interprofessional collaboration helps in bringing the ideas not from just a nursing perspective. So as we had a nurse scientist and we had a leadership, and also from the education and also from the dietitian side. So what we are planning is that because this helped us having an professional team for our next article, we are planning to have other teams also join us in writing the articles. Don't dwell on ideas. If you have an idea, reach out to the right people, form a team, and start reading and writing. The best part was our rewards. So in August 2021, our article was published in the A1 newsletter, which is a very popular product. Our article was one of the 5 articles submitted for the 2022 Best of Jargon Writing Award. And this is a very prestigious award. We did not get the award though. We were chosen to receive, but we did not. But we were very proud. They were also very proud for the status of our article. Our article was chosen for the, thank you. Our article was chosen for the originality of the work, clarity and scholariness of the writing, potential to significantly affect the care of women, infant, childbearing families, and the interdisciplinary importance of the work. We got to present in various conferences as poster and podium presenters. Even though we published our article in 2021, it's 2023, I'm still talking about this publication. So we have spoken about this article in international conferences, national conferences, local conferences, service line conferences. And not only that, we were able to disseminate into various hospitals, and they are also following our infant-based or infant-driven feeding. This would not have been possible without my team. So I would like to thank my co-authors, Becky, Debbie, and Annie, for being a part of the journey. Thank you all.